Hello, everyone, and welcome to the Center for Health Design's Voices of the Industry webinar, Back to the Future, a time to reflect, regroup, and rethink. I'm Donna Deckard, Director of Strategic Projects at the Center, and I'll be your host for today's panel discussion. I'm delighted to be here, and I think you will find today's session informative and enlightening. Today's webinar is the final session of a four-part Voices of the Industry series, which highlights the experiences, insights, and expectations from exemplars of the healthcare and design industries. We're excited that so many of you have decided to join us for this discussion today. We have the unique opportunity to hear from members of the Built Environment Network, or BEN. BEN is the Center's collegial network of executive-level facilities professionals and industry partners who are dedicated to improving quality, safety, and sustainability in healthcare. They will share their insights on current challenges within their health systems and how they're beginning to make decisions in a more data-driven way. They will also share their real-world experiences and examples. And most importantly, they'll offer insights to help you on a path forward and shed light on their views of the future. Throughout the discussion, please feel free to ask questions of the panelists. When you have a question or comment, simply type it into the Q&A pod, which is located at the bottom of the screen. On some of the mobile devices, it may be located at the top of your screen. We'll keep time at the end of the session to answer questions. I also encourage you to chat with me and fellow attendees in the chat window during the webinar. We also are offering CEUs for this webinar, the AIA verification form, the EDAC verification form, and requests for a certificate will be available in the chat window. In order to earn credit, you will need to complete the appropriate forms. For AIA credit, please fill out the verification form and then email it to Natalie Gonzalez. Her email is listed on the form. And to receive a certificate of completion, fill out the request form via a WUFU link located within the chat window. And to earn EDAC credit, retain the verification form for your records and self-submit the credit to Scantron at the time of your EDAC renewal. Now, before you meet our moderator and panelists, I want to thank Pat Kraft, Acorn VAC, and Samsung, our sponsor partners, whose generous support has helped to make today's Voices of the Industry session possible. They, along with the Center, share a vision to provide you this important information and interactive experience. We appreciate their longstanding commitment to our industry and their collective efforts to make a difference in the built environment for people and their health and wellness. So now, without further ado, I am delighted to introduce our moderator for today. Mike LaMont is the former Vice President of Facilities Management at Rush University Medical Center. He was there from 2006 through 2020. In that role, Mike managed capital projects, corporate real estate, medical center engineering, parking and utilities, and occupational safety. His responsibilities included planning and oversight of all research, clinical, and administrative capital projects, and he managed all aspects of facility life safety projects. Mike, I'm turning the session over to you, and I'll have you introduce our panelists.
Okay, thank you, Donna. First, we have Clayton Mitchell, who is the Senior Vice President at Thomas Jefferson University and Jefferson Health. Welcome, Clayton. Next, we have Mike McKay, Director of Planning, Design, and Construction at the University of Wisconsin Health. Next, we have Alicia Wachtel, who is the Executive Director of Planning, Design, and Construction at Cedars Sinai Health System. Next, we have Jordan Cram, who is the Chief Executive Officer at Enstoa. Finally, we have Nate Chandler, who is General Manager at Steelcase Health. And now let's get started. I'd like to thank the panelists for joining us today. And to our viewers, a hearty welcome. We have people listening in from across the US and around the world today. Let's find out where people are listening in from. So I'd like all our viewers to type in where they are from in the chat window. And we'll get started. Coming out of the pandemic, health systems are wrestling with new issues that are very different from the pain points they had 2 years ago. As they assess where they are now, they are rethinking how to utilize their current and future space. How best to design, reconfigure, and use space is a key top-of-mind topic. Phrases such as condense to enrich or contract to expand come to mind. Needing more space has been flipped to perhaps needing less space, but more flexible space, along with the need to balance and allocate space to meet new demands for both patient and staff needs, along with a renewed focus on how to reduce healthcare's impact on the environment. As you work with health systems, it's important that you understand their pain points today and what their future gaps might be, and learn how they are making decisions in a more data-driven way. Today, we're going to briefly touch on several topics to give you a sense of what members of the Ben Group have been discussing. These include health system growing pains, real estate rationalization and modernization, data-driven decision-making, and finally, clinician and staff respite issues. We don't have clear answers for you, but you will hear more about what the current issues are and what is being considered so you can be a more effective partner. Please remember to write your questions in the Q&A tab located at the bottom of the screen, and we'll answer questions at the end of the presentation. So let's begin about talking about growing pains and real estate rationalization issues. Prior to the pandemic, many organizations were developing plans to expand their footprint to meet what seemed like ever-increasing space needs. The pandemic hits, and now we have a more remote hybrid workforce, along with changes in care delivery, such as telehealth and the increase in building costs, and plans for the future have stopped or are being altered and considered differently. Health systems today are managing a portfolio of assets and must think about the system as a whole when they're planning for the future and weigh all the investment decisions to develop their plans. We'll start out with a question to Mitch. Mitch, can you share with us what you are considering at Jefferson Health as they develop their future business and strategic facility plans?
Hey, thanks, Mike. For Jefferson over the past decade, healthcare it's pretty much experienced a significant consolidation through mergers and acquisitions. And we in particular have experienced our own growth through M&A. We're evolved from a 3-hospital, $1.5 billion health system in 2012 to an 18-hospital plus university, $9 billion entity today. So integrating myriad and disparate systems and organizations while maintaining care delivery operations under a lot of the pressures that we have associated with decreasing revenue streams, intense competition, significant deferred maintenance backlogs, and really changing consumer preferences. It's kind of like attempting to modify an airplane in flight. We got to plot to the future, but we got to keep operations going today. And seeking a balance across strategic capital investments for growth, expansion, modernization, and sustainment. We're somewhat challenged with a significantly aged real estate portfolio fraught with redundancies and operational efficiencies. And I suspect that's probably the case across industry. And in a sense, we've got to transition from an inherited portfolio of facilities assets to a more retail-oriented strategy, which enables our system to provide the right care in the right location at the right time. So that comment you made about contracting to expand is especially relevant for us. We've got over 240 sites of service, and we think we need to get down somewhere close to 50 in order to create a financially sustainable model. A sound strategic plan and understanding of facilities data are essential to efforts to develop strategic real estate initiatives that are aligned with our health system's evolving vision. And that said, in many instances, like Jefferson, a key attribute that the system must develop is the ability to transition from a site-specific, site-centric, independent-oriented mindset to a network-centric, integrated systems mindset. This is a challenge we're working to address by helping to foster network organization through the real estate portfolio. And I'm sure there's other insights we'll provide as this discussion continues.
I think Mike McKay might have a similar strategic facility outlook. Mike?
Yes, Mike, and thanks, Mitch. For us here at UW Health in Madison, Wisconsin, it's very similar to what Mitch described in terms of our system growth and how we are expanding, but contracting to expand as well. We are centered on delivering the right care at the right time in the right place. So it is a lot of planning effort across the system of care and working with our providers and care teams on making sure we're getting those patients the right access to the right services in those right places. For us, it's focused around our work streams across the system of care. And those are inpatient, surgery, and ambulatory are the big three. Ancillary and diagnostic services is next. Then facility support services and supply chain. And then last but not least, administrative. And those first four work streams are what we consider highly on stage, squarely in the spotlight. And they're supported by the last two, which we're really trying to keep off stage. And all six are requiring robust infrastructure, a lot of which became more evident to us during the pandemic. And so with that mindset, we are moving very fast towards this system of care mindset with everything we're doing in our approach to our real estate footprint. We are the state's leading tertiary and quaternary care system, and our approach has to be different in each of those work streams. So for inpatient, surgery, and ambulatory, those big three, as I mentioned, it is about expansion, but also alignment with what we call synergistic consolidation. So again, that's focused on the right patient in the right place with the right services. And then tied closely to those three are the ancillary and diagnostic support, but they're too getting those in the right adjacencies to the big three and supporting those services across the system of care, but taking a look at that with an inpatient and outpatient through that type of focus. And then with the last two, the facility support services, the supply chain and administrative, it's more focused on maximizing our efficiencies and technology in order to reduce the space and real estate that we use for those services. And this we call leaning the system of care. And so as we plan for space and modernization of our space, the planning is driven by medical operations planning, the operational model, workflows, and processes that support those functions in those type of spaces. So I always like to say form must follow function in that case.
Thank you, Mike. Alicia, at Cedars Sinai, what growing pains, portfolio issues, and some space challenges are you faced with?
Yeah, similarly to Mike and Mitch, we are switching, converting, evolving from medical center-centric to a very robust, geographically extended system. And this is happening through affiliations and acquisitions. And the build platform it's typically the entry point into all our new markets. And what we encounter when we through our affiliations and entering those markets is that what is existing there cannot by itself support our vision of growth. So real estate becomes our currency. It's what allows us to support the physician recruitment, the establishment of new service lines in regions where we had no previous presence. But that real estate is not always available, or it's not always available in the manner in which we need it. Cedars Sinai and our affiliates, we are located in urban areas. So real estate is scarce and it's very expensive. So many times medical uses are limited by the cities. I know nobody feels sorry for me, but the city of Beverly Hills doesn't allow much medical use, right? But we are in Beverly Hills, what can we do? So we're not finding those places because ordinances are causing us to place our very complex medical facilities, sometimes with labs and pharmacies, into office buildings, and they don't have the right infrastructure. This is very costly for us, and we're investing a tremendous amount of money in buildings that are not ours. But we need to do it, and then we need to find a way to maintain it, again, in buildings that are not ours. So it's truly challenging. Now, our system approach is geared to make the highest and best use of every space, and that's where our transformation is happening. So from our academic medical center, which provides tertiary and quaternary care, and also all our research and academic functions, we have now a system of community hospitals, and how we all come together, it's really important. And we all wish, that we could modernize space in a very, easy and facile manner, and that is not the case. It's one of the major challenges that we encounter. And as we talk about modernizing our main medical center, our census at Cedars Sinai is always above the number of beds that we have. And that limits us to when can we do those modernization projects. We never have the ability to open space to modernize. And especially during the pandemic, we were allowed to expand our capacity by using some units in non-customary ways to increase our census. That is changing either this month or next month. So we will not be able to deliver care like Department of Health Services allowed us before. And that's going to diminish our inpatient capacity. I suspect that then we'll have even less of an opportunity to modernize within our medical center, and that means we'll be serving less patients. The other aspect besides patients that we constantly encounter, and it's my biggest growing pain right now, is the pace at which we are recruiting physicians. And that pace is larger or faster than our ability to create space. So it's resulting in us not having space available, both clinical and research, to serve those incoming groups with their patients. What that does is we're paying more because we're in a rush. We need to turn it really fast. The facilities are not ideal. I sound like I'm complaining, but you said growing pain, so that's what it is. And it's also for the audience, it's tilting us because we need to move so fast to use the same teams over and over again. So to partner with the same team, so it limits somehow competition. So I'm really looking forward to be able to slow the pace in which we need to deliver space. And also we are all, I believe, looking forward to supply chain being again on our side.
Mike, I just like to sort of emphasize a point. I mean, our challenges are exactly the same as the ones outlined by Alicia. And though our modernization efforts are very nascent at this juncture, we're working to emphasize the importance of enterprise planning and programming, and strategic planning as a means of at least charting a course for where we need to go in terms of modernization efforts, especially for our 18 hospital. So our fiscal year 23 budget includes significant budget increases for those functions, planning specifically, programming, and facilities optimization consultants. Our mantra is like plan the work, then work the plan. And we recently filled a new position as Director Capital Program Development. I'm really charged with putting together the strategies and the comprehensive capital program that we need to balance growth and expansion, which are typically the things that health systems are really focused on, the shiny new stuff. But as importantly, modernization and and maintenance. We've begun by creating a model of anticipated facilities condition assessment spikes for each of our buildings to really kind of give us an indicator of where we might think a full bore recapitalization and modernization of a facility is probably preferred. And we're looking to sort of change or evolve the mindset of our leadership to have modernization equal on par with expansion and growth as an objective going forward.
Thanks, Mitch. And so now we've heard the high level view of what the growing pains might be in managing these large portfolio of assets. And I'd like to dive a little deeper into some specific changes with the panel. So can we talk a little bit about coming out of the pandemic, things such as telehealth and how that affected you and changes, as well as other workforce changes that you've incorporated or need to do in order to prepare flexible spaces for your staff?
You know, given the reductions in the revenue streams, reduced reimbursables and a lot of other competitive cost pressures, we were already on the track for consolidating our administrative spaces, downsizing square footage per staff, doing that prior to COVID. We'd also made some pretty significant investments in telemedicine, again, well before COVID. And those investments and those activities paid significant dividends, but they were kind of moving at a snail's pace. COVID hyper accelerated that pace. I think really in a good way. If there's any good that came out of COVID, it was prompting at least our system to do some things in terms of decisions that we needed to be doing anyway to increase our operational efficiencies and really drive down our costs. So our issue now is to better understand the impacts of that changed work environment post-COVID. Quantifying those impacts and understanding how is that really going to affect our capital programs going forward? How does that affect how we use space going forward? And that's still a work in progress. And so our system leaves that to the department to understand, do you have a hybrid model, a remote model, an in-place model, or some mixture of the three? We're still trying to figure that out. In an environment where care delivery processes, technology, and patient preferences are evolving at a really hyper accelerated rate, we're emphasizing the importance of flexibility and agility in our design and construction efforts to position us moving forward.
Yeah, it's interesting how we all experience very similar things, but at some point it becomes cultural, right? So the pandemic has propelled us into hybrid work environments, right? But we didn't necessarily design our facilities that way. So right now, I think that we're all encountering that we have more administrative space due to the hybrid work environment. Now at Cedars, we are very slowly and very delicately working with our physicians, because talk about cultural shift, right? To evaluate who absolutely needs to be in the medical center and who can be maybe a mile away, 2 miles away, where we have plenty of administrative space. The space is available and the space is wonderful. It's going to take us a while to work with the cultural shift of, I don't need to be 3 steps away. So that's a challenge. So on the outpatient clinical side, we had moved to what we call the transform model. And that model was prior to the pandemic. That model is extremely collaborative. What that model does is places physicians and staff in collaboration spaces where they can have those conversations. And there's no offices, pretty much. And then the pandemic hits, and those collaboration spaces become unusable. You can't have all these people together in a collaboration space. And now we have no offices. So where do you do telemedicine? So it's really a very interesting view at, when we all talk about trends and models and transformation, and then something happens and you've been transforming in a direction that didn't, foresee a pandemic. But our facilities are flexible enough where we can start adjusting to new ways of work in those situations. But the new ones that we are designing are more of a hybrid model. They're not the full collaborative, no office space in our clinical spaces. And we've seen telemedicine decrease to almost pre-pandemic levels. So we do need still to see what's going to happen with telemedicine and how we're working, and then work very closely with the ratios of collaboration space versus private space.
So we're very similar at UW Health to what Alicia described, and Mitch as well. But it's been interesting how it's different across our different work streams. And to Mitch's point, the pandemic has really accelerated a lot of that pace of change and planning. For UW Health, we had already embarked on the optimization planning across these 6 work streams. We had actually had board approval of our ambulatory optimization plan in the year prior to the pandemic, and we're embarking on that process while our teams were continuing their planning work across the other work streams. So with the pandemic, it caused us to pause, but it also caused us to refocus. So a couple of examples for us across those work streams. With inpatient, it's really now a focus on building flexibility into our inpatient system of care. It's focused on acuity adaptable universal patient rooms in care units. And then with those optimization plans and those care units more in sync and aligned with surgery and supported by ancillary and diagnostic services. So it's really causing us to look at the system of care as a whole and get those types of services in the right place. On ambulatory, it's very similar to what Alicia was describing. Care teams, integrated care teams now having to spread out with social distancing. It's causing us to really look at the type of work that's being done within those spaces, how they can do that work. Can some of that be done from a remote location? Can we put folks in more separated spaces? So it is changing the work model in the clinics behind the scenes. But the overall planning was validated actually through the pandemic, and our ambulatory optimization plan is moving forward for us. Really focusing though on maximizing on and off stage space for staff, and including that space to support telehealth, which we went through the same changes as Alicia described. We're really trying to now get some of our providers out of the exam rooms when they weren't seeing patients. They took those spaces over for the privacy and the safety and started doing telehealth from those spaces. So we're now trying to integrate telehealth into specialized spaces so the exam rooms can be returned to inpatient care. Facility support services, we're really trying to build redundancy across our system of care, really focused on supply chain redundancy and capacity, and putting facilities in the right locations to maximize that effect if we can. And then on admin, we've touched on that. We've got a lot of empty office space that's available and for sale. We're trying to look at collapsing and consolidating our space and looking at, as we do that, how, again, the workflows that our departments have, how they work. Can that work be done remotely? When do they need to be in the office, and for what functions is driving a lot of that planning? And then across all of it, though, is really this hyped up and needed hyped up focus on how our staff work. With the burnout that we're experiencing across the entire system of care with providers, nurses, even administrative and support staff, it's really paramount now that we design spaces with purpose to really support staff, how they work, when they work, and giving them breaks from work while they're at work. And we're going to be touching on more of that, I think, towards the end here with some other comments with the panelists. But that's what's really driving a lot of our planning right now, Mike.
Yeah, I think Mike LaMont, you might be muted, but I'm so.
I am muted. You're there.
Okay, we got you covered, Mike. Hey,
I'm back on, everyone. So Nate, I'd like to hear our audience, have our audience hear how an industry partner such as Steelcase is helping to create the workforce environments that support these new priorities.
Yeah, you bet, Mike. And I liked a couple of things that Mike McKay said about establishing community and culture. And the audience can imagine here at Steelcase with the notion of hybrid work. I mean, we're spending a lot of time thinking about the role of the office and the workplace and the design and what the future holds for us. And over the course of the last few decades, there have been evolutionary moments for the workplace. We're in the middle of one right now. And I think the reality is we're not going to entice everyone to come back into the office with free snacks and fun events. These gestures aren't going to overcome long commute times, the need to, put your work wardrobe back on, high gas prices. So, this is an opportunity. And I think it's really critical that we start to think about the workplace design that makes the commute worth the while. And, one of the ways that we're thinking about this, we're taking inspiration from the neighborhood. And a lot of the audience will know Jane Jacobs' book, her seminal book on urban planning, The Death and the Life of Great American Cities. And the premise of that book, which is really relevant today, is that people really thrive in diverse neighborhoods. And where you have homes and bustling sidewalks, you have shops, you have parks, you have public spaces, and all these spaces come together and they coexist and they create an extraordinary variety of experiences. And this, those variety of experiences create vitality and energy. So it's not static, they change, they adopt, and it's in these neighborhoods where relationships get formed, a sense of belonging and a sense of trust, those elements of community. So when we're thinking about designing a workplace that is really worth the commute, it's not about simply fitting more people into less space. That's not going to create what we need to create. And we have to remember that healthcare systems on the admin side as well, we're competing for finance and accounting and marketing roles and HR roles. So, we have to create administrative spaces that provide this, a really good reason to come into the office, even in hybrid situations. So, neighborhoods at work, like the ones we live in, are a home base for people and teams. It's thinking about how you have a variety of interconnected spaces that support different types of work. A mixture of uses. They have a natural flow from one another, and they would include things like individual spaces where it's assigned to one person, or you might assign those to a team. Collaboration spaces, which is really important for in-person and virtual interactions that support the ways that people come together. And importantly, it's having those moments for appropriate privacy. Nobody wants to be the loud talker when you're on a Teams call like this, sitting next to your colleagues. So do you have moments where you can step into a room, like a pod, for example, have a Teams meeting or a Zoom meeting, and not bother your coworkers? And then importantly, moments of rejuvenation. We'll talk about this on the panel. And then as the teams come together, where you can gather, socialize with your teammates, again, building that community. So, we really see this moment when we're all thinking about how we optimize our real estate strategy. It's an opportunity to inject new life and energy into the workplace.
Thank you, Nate. It's really helpful to get that industry perspective, someone such as Steelcase working with other clients to really look at the whole picture, because I think individual facility managers, it's very hard for them to see what's going on across the board. So I think a company like Steelcase brings it together. So now I'd like to ask a question, again, open it up to the panel. As facility executives, you're being asked to manage your space portfolios in different ways, as you've explained, and cost is always a factor in this business transformation. So how are you and the executive team making decisions about facilities differently now? And if you could go a little bit deeper into the hows and whys and how you're doing it.
Just listening to Nate, it would suggest that, we need to be part behavioral scientists, part cultural anthropologists. I'm going to add another hat to that and say we need to also be economists, right? Because it's really about how do we balance all of those, and how do we anticipate cost trends that are going to impact that real estate portfolio over time, but that real estate portfolio has to reflect the opportunities that we need to enhance productivity and experience for everyone who uses our facilities. So although most systems like ours have a well-developed strategic plan for care delivery, translating those plans can be very challenging. And it's a very dynamic environment, right? And so just in the space of 2 years, the whole way that we look at using workspaces essentially flipped. And those capital plans that we had in place before are still pretty much there, but now we have to say, hey, are they still still relevant? So given this market volatility and uncertainty, that ultimately impacts project costs. And we've got to ask, typically we've been asking, we've been saying these projects are too expensive. With that volatility and with the dynamics of what's going on, I think we have to change the question to, does the business case work? Are we still going to achieve that ROI? And as noted earlier, at Jefferson, we're driving the enterprise to invest more in strategic planning, because I think flexibility and agility in not only how we construct and design spaces, but the utilization and ensuring that those designs enable that dynamic flexibility and work styles is built into our facilities. Many of which, when we build a new facility at Jefferson, we got to plan. We're more than likely going to have that facility for 30 to 40 years. So have we built it in a way that it can evolve from a physical standpoint, and really increasingly from a digital standpoint. So we're leveraging data from our clinical operations, strategy, finance, marketing, just all of the various stakeholders we're working with to assist the organization to take a more network-centric, integrated approach to how we plan out our facilities going out into the future. So because we need to not only better quantify our requirements so that we have better clarity on what's going on in the streets. We firmly believe that if we're very clear in what we are asking for, we can position industry to meet those needs in a reasonable cost way. I don't say lowest cost because, again, in this market, we're looking at hyperinflation at 15 to 18%. So what we invest in, we have to have some assurances that it's going to align with everything that Nate and Alicia and Mike talked about in terms of operational efficiency, productivity, and really that cultural shift that's gone in our environment. And we feel like the more clarity that we have on future requirements, the better we are able to anticipate those trends and develop acquisition strategies to meet that really rapidly evolving model. So we, ultimately our executive leadership, decisions are made with 5 essential focus areas. Will this help us transform care delivery? Is this investment going to help us build financial stability, sustainability? Will this investment help us enhance systemness? Does this investment help us evolve culture and workforce? I think the majority of what Nate just talked about there. And will this investment help us cultivate community health and wellness, which speaks to where do we need to be in a community in terms of our footprint and in what size, what types of capabilities. I think everything that Mike talked about is right place, the right care, at the right time.
Yeah, Mitch, the only, absolutely you touched on all the super important points that should answer for our audience that question of, so when are you going to build that building you were talking about, right? I think we're all slowing down to really study. We're doing, at least we are doing many more feasibility studies. We are working on infusing the business case with a very realistic cost model from the built environment. And the other part that comes into consideration is the changes in reimbursement. So we've always talked about those, and we're always trying to predict how fast they will happen. The latest ones that will definitely affect Cedars Sinai tremendously are changes in reimbursement that relate to orthopedic surgeries. So we built a very sophisticated platform of hospital-based ambulatory surgical centers that are incredible. They're truly incredible. And what could happen is that we might not, the insurance will not pay us for hospital-based orthopedic procedures. So they need to happen only on an ASC. For now, we can do them either way. But it's appearing that we might not be able to do that. So then what do? Here we have a whole sophisticated platform of operating suites. And we don't have many of the fast ASC turnaround facilities. So if we build those, what do we do with the platform that we have now? What are we going to be able to do there, and what can we do on the new one? So all that business case development informs what we need to do, what we need to develop. So we're not always ready to move ahead with our plans. Right now, we are embarking on we're calling it an OR master plan, which is what do we have in the system? Where is it? What can we do with it? What type of reimbursement we expect? And a lot of that is our strategic business development group. And then from the build platform side is how can we support new models? How long is it going to take us to build? Where can we build them? What are they going to serve? So unless we bring those two together, we are not going to be able to find a solution that's similar to what you were describing, Mitch, that it's still built on very strong data analytics and looking at the future.
So Alicia, you just left us with a whole lot of questions there at the end of your comments. So let's stick with planning, because it's answering those questions happens in the planning phase. And so Mike at University of Wisconsin, how are you and your team using science and data in your planning?
Well, quite robustly, I must say. And to Alicia and Mitch's point, revenue and business planning is part of that science and data. But also as we translate through that type of information into how it affects actual spatial plans, we exist in planning, design, and construction as a resource for our leadership in that planning design effort, but they're not going to make decisions based on just our pure experience and the talent and experiences that our team brings. So we do use a lot of data in the management of our space and the design of new space. Some of those factors include things like occupancy. We're looking at it through the lens of not only being based on the planning and design guidelines, but then set against benchmarks that we have within the system of care, such as things like square foot per FTE, or the use and utilization of that space, looking at how often is the space occupied and being used. We're tracking the use of space in real time every day, so that we can see if it's serving more than one use, can it serve additional uses and be used in different ways. Related to that is work utilization. What function of the work is the space supporting, and is it necessary? Can it also be shared by other departments and other functions? So we're applying those lenses to that as well. Cost is also another factor. We've touched on that. We want space that can generate revenue for the system of care, but we also know there's an operational cost to this space. And so we need to understand what that is and project that forward. And that varies depending on whether it's inpatient space, outpatient space, or administrative space. Even with our administrative space, which is often leased and not under our control, we're still looking at what is the cost of common area maintenance and utilities on that space. And then we're setting that information against benchmarks again, and using it like cost per FTE or service line as a way to help us measure efficiency of the use of space. We have technology platforms in place that we use. FM Systems is our system of choice right now, in conjunction with ServiceNow, on how we're looking at and analyzing this data in real time. It's helping us maximize and optimize the space that we have, and then the space that we're planning. We also have multidisciplinary cross-functional committees set up across the system of care that our planning, design, and construction group facilitates and interacts with. We have a medical operations planning committee, as I mentioned before, that's looking at the planning work, the strategic planning work across our 6 work streams. We have a space committee, not outer space, but inner space and physical real space. And we have an intermingled space committee that we share with campus and the use of the School of Medicine's use of our space. And then we have a strategic facilities planning committee. Mitch mentioned that. We've been invested in that effort for quite some time. And that committee is ultimately the ones who approve the use of space, both existing space and changes to that, as well as new space. So science and data is heavily used, and it is our guide, Mike, in everything that we do in our world.
Thanks, Mike. It sure looks like our audience has heard strongly from our panel of that data is driving these facility decision-making more than ever. Jordan, your organization helps facility executives better manage their space. How and what have you done to help them use all this data?
Well, my fellow panelists here have really tough decisions that require accuracy in the underlying information, and we're really working to provide that in the planning and decision process. We view the buildings in the portfolio as organic elements, not a specific project, not a fixed structure, and we kind of think of this as the organic portfolio. One thing we're doing with an organization, Yale New Haven Health in Connecticut, is to capture the reality existing conditions. So for existing buildings, we capture the real environment. We have a cart and a backpack to zoom through the spaces. It's kind of like Google cars that drove around capturing reality. We produce a detailed and super accurate BIM file so that existing buildings can be viewed in 3D. And not just the geometry or the location of assets, but we also have a view into the images, the panorama pictures of all spaces. So users and planners get the equivalent of street view. Where is it? How big is it? What's the layout? The exact look and feel of the space. The building could be across town. It could be in another state, but it can still be viewed and visited virtually. So how does it help? It allows strategic planning and scenarios to be analyzed without any doubt of existing conditions. It kind of just removes that from the equation. Building data are totally accurate. If the pharmacy says it's 2,000 square feet, it's 2,000 square feet, and it looks exactly like this. Space data is then, as my colleagues have mentioned, the value, it's mapped to departments. Departments are mapped to clinical services, to revenue, and to margin. And I think it was Mike that mentioned this, that computational planning is then possible. And this is just awesome because algorithms can produce scenarios that aren't intuitively obvious to, or even possible through observation and brainstorming. It's kind of like you have an extra decision partner in the room with those models. They're based on space usage, assignments, adjacency to patient clusters, and clinical services. There's a lot of other benefits. Projects can start without the need of any on-site surveys. Architects get going immediately to develop conceptual plans. At the end of the project, we would again reach probably before ceilings are hung and at substantial completion. Can also measure things like Wi-Fi strength, light levels at task and standing height, noise, and other elements. And so the solution is, really the idea is like getting an EKG and a CT scan for your building. So as a planner, you have all that data to make a proper diagnosis. So as I mentioned, there's not doubt in the accuracy of the information.
Jordan, you're working in that manner with us as well, your team. And two things to add to the usability of this. We call it digital facilities, what your team has created for us. In addition to everything that you mentioned, it also has become what we call our space bank. So when a space, instead of different departments kind of like holding on to their space so nobody else is gonna take it away from me, we can now have a bank where you deposit that space and then you can take another space. But the only way that we can keep up is with the digital facilities platform that you created for us. And in parallel to that, another great use of data has been the creation of our lessons learned platform, which as we progress with projects, we capture them in this interactive dashboard. And especially when we build so much at the same time that we don't necessarily have time to compare notes, it allows us to quickly search what happened with that kind of project. What have we encountered in pharmacies? We can even, we're starting to tie it to the digital facilities. So you can see this is where that problem arose. So it's a very fun and sophisticated way to share information.
Yeah, thanks, Alicia. I mean, I think for everybody, to just kind of get the point across, it's really important that we make technology work for people and not the other way around. The lessons learned, Alicia mentions, are extremely valuable, especially in this environment where young professionals are stepping up and organizations are dealing with churn. So with that as a backdrop, Cedars Sinai needed a way to create structured action plans from loose and unstructured information. We extract the text from surveys and lessons learned. Machine learning categorizes this information by sentiment, emotion, and functional content. The outputs of the machine learning module result in a structured table of lessons that can be mapped back to ongoing and future projects. So here, like a machine is automating a process that is super tedious and time consuming for a person. The approach allows lessons learned to be captured in a natural, free-form way and then applied to future risks in a systematic and structured way. It's similar to my example on the organic portfolio. We believe it's really important that to focus on real data the teams are producing as a byproduct of their work. Like people are just too busy to kind of separately go and enter and manage data. So we need to figure out how we can glean that information. It's sort of like an analogy could be like how the motion of a car through an alternator charges a battery. So the car's purpose is to get a passenger safely to a destination. But by leveraging the byproduct of that motion, we can generate electricity. And I think that's a really important principle as the project teams are focused on strategic planning, design, construction, operations. They're just too busy to manage data on its own. So we need to mine and use the data that is really a byproduct of the ordinary work.
So thank you, panel, for the high-level discussion on portfolio and asset management, modernization, and data. Very, very fascinating and certainly a lot of depth there. So now we're going to change gears and talk about a specific space issue that has come up as a result of the pandemic. We choose to highlight this issue because it's a new, important issue that needs to be addressed, especially with the recruitment and staffing issues that everyone is facing. This is the issue of clinician and staff burnout. And I think Nate, I'd like you to kick off the discussion on this because I know Steelcase has been involved with many clients on this.
Yeah, Mike, and it's so good and essential that we talk about this today. Healthcare is a service industry, and one of the key tenets of a service industry is take care of your employees, and if you do that, they're going to take care of your customers. And I think for clinical teams, absolutely essential today. The good news is I think everybody, meaning the healthcare systems, are working to respond to the critical situation facing the clinical teams. it's been an intense couple of years, no doubt about it. But even before the pandemic, what we were seeing is that the clinician work areas were really struggling to keep up. Technology was coming at them. It's always been a collaborative environment, but that collaboration has become just increasingly important. And these can be areas of especially in the height of the pandemic, they were very chaotic work areas, which only exacerbated the sense of burnout. And so the new need that we see arising is how do we design for and provide moments for the clinical team so that they can have some respite, that they can have a chance to take a time out and collect themselves. And we've been talking to healthcare systems and members of BIN and others, and we're starting to land on some key learnings I'd like to share. And sometimes some of these key learnings are obvious but you don't recognize them until you hear them. So the first one I'm going to share is respite isn't the same as the lounge area. So lounge spaces certainly have a purpose. The teams eat there, they have conversations there with colleagues, they can catch up on documentation, but they're really not well suited for respite, which tends to be more of an individual activity. And we can design these spaces if we do so purposely and intentionally. They can certainly be smaller, where one person can take a time out. They can kind of let their emotions go and they can collect themselves. So, that it's not easy to do that in lounge areas. The other thing that's a key takeaway for us is, the clinicians endure high stress situations, but the moments of respite really aren't encouraged. And that can be because of a few things. One, respite could be obstructed by the inconvenience or insufficient affordances. Cultural norms have a play. Unaccommodating workflow certainly have a play. And I think this is probably one of the most important drivers of this. Clinicians simply don't want to leave their unit to take a personal moment. I mean, they're very committed. They want to stay in the space. They don't want to leave. When they do leave, they escape to restrooms or escape to stairwells for that emotional reset. Not exactly the kind of space that's going to give you that moment of respite. So there are a lot of cultural issues at play, a lot of administrative issues at play that are causing the burnout. But we certainly have an opportunity for space to be designed for where the inpatient work can better support the workflows, as well as these moments of rejuvenation and respite.
So to our facility executives here, Mitch, Mike, and Alicia, how are you balancing this issue that we have brought up now?
Well, Nate sets the stage pretty well. So it's staff experience is patient experience. And we've learned that was reinforced during the pandemic at all levels. And from a planning perspective, I also want to say to the audience, gone are the days of making our space programs work at the expense of needed space for staff. I know we're always trying to pound more program into available space, and cost drives a lot of things. And in past planning experiences that I've had, that usually comes at the expense of some of the support spaces and certainly the staff space. And as Nate touched on, even spaces like lounge spaces and respite spaces, it's easy for a space efficiency point of view to group all those things together and put them somewhere, but they're separated from the units, and our providers aren't going to work that way. And for us, we found that out, in spades during the pandemic when we restricted visitors, patient family members and visitors to our buildings to keep everybody safe with COVID. We used a lot of that soft space and family space to spread our staff out. And their workflows have gotten better, they work better. And now we're trying to figure out how to come back after the pandemic and take that needed space back as well for our patients, families, and visitors. And it's really becoming this balancing act. But I think we've got to focus on that. We got to keep in our forefront that healthcare is people-centric. We want to design our way out of problems sometimes, and we like to go down that path, not thinking about the people that are using that space. So I would just say we need to keep that on the top of mind moving forward. And it's critical for us across the entire realm, inpatient, outpatient, ambulatory, and even administrative space in this day and age, the way we work.
Yes, absolutely. And I think we were making strides. We did all as an industry and our healthcare design partners, big strides in creating spaces for respite. What happened during the pandemic is those spaces became hotspots for transmission of COVID. So now we found that our staff is getting sick and then we can't deliver care. So on top of it, of the burnout, the spaces weren't really serving during the pandemic the needs that we needed because we had to get people out of them. So what we are doing and have been doing in our newer projects is really look at the perimeter of our buildings. We think that's where the answer is, because balancing the use of perimeter, most of you remember that perimeter used to be all patient rooms or all exam rooms or all offices. We don't do that anymore. We need to balance the perimeter to give our patients, to give our staff, to give families the views, the air, the light, but also we need to start notching the perimeter and getting those in and outs in the perimeter that allow us to build patios, balconies, outdoor areas of respite specifically dedicated to staff, separate from visitors and patients. So now we're looking at the perimeter as our hottest real estate. And I know that Mitch, like he's been saying, it's more expensive. Yes, it is, because now it's not a box, but the box is not serving our purposes the way it used to.
Yeah, I think we're looking for that sweet spot between the workspace requirements, how our people work, how we promote productivity, how we promote wellness, all with that spin of affordability and making sure that we're making our business cases work. And I don't want to repeat anything that Nate, Mike, and Alicia said. I ditto it all. I think staff and physician burnout issues are complicated, particularly for a system like ours, because of the need to modernize. And I snuck a peek at one of the questions, and it says, "What does modernization really mean?" And I think simplistically, I'll say this is the way that I've described it with our system. We track deferred maintenance pretty hard, and we set up budgets based on addressing that deferred maintenance. But deferred maintenance only gets you back to the default state of the building. So if you have a 1985 building and you take care of the maintenance, you have essentially, okay, from a maintenance standpoint, I have a 2020 building, but from a utilization and a layout standpoint, it's still a 1985 building. So I think for us, modernization means, what is that next level of care delivery? Back to Mike, your point, Mike McKay, form follows function. So if the function evolves, the form needs to evolve. And so it's not just, you just can't address your maintenance issues and get to the place that we need in terms of all of these different factors we're talking about in today's state. And it's not just about care delivery, it's about retention of patients, but more importantly, physicians and staff. They need to be in inspired spaces. And so I think for us, it's really, in a collaborative way, in a comprehensive way, how do we begin to balance our investments to sort of address all of those issues in time for our portfolio?
Yeah, Mitch, I think these are the moments that kind of really help us rebalance priorities, right? I mean, we get a clear perspective on what really drives outcomes in the long term. Clinician work areas are the nexus point of I work, like documentation, and then we work, like high traffic collaborative areas of care. And, we've really focused as an industry on efficiency of those spaces, which is really important. But I think keeping the clinician experience in the forefront as a priority is going to be really important, because if you don't make that investment now, it's going to be more costly down the road. And I think the challenge for as an industry for us is how do we continue to evolve those workspaces so that, like Alicia was mentioning, you purposely program those areas that are adjacent or at least easily and quickly accessed with minimal disruptions to existing workflows. So it's the I, the we, and the more emphasis on the I for that clinical staff so they can have those moments of respite.
Well, thank you, panel, for your insights again on the very high level real estate rationalization, staff respite spaces, some of these emerging issues that we chose to focus on today. So we're going to open it up to some questions from the audience. We've already had some questions come in, and we'll start with a real easy one, maybe to Alicia and Mike, about modernization. And what does that really mean to modernize your space? Either one of you can jump in on this one.
Yeah, modernize means, so let me backtrack for a sec. We all live in facilities that are old in general. I mean, our hospital, our main hospital with 1,000 beds was built in the 70s. Our other hospital is even older, the 50s, and then some of our affiliates are as old as that. Same with clinical outpatient space. So those spaces, those facilities, not only from the infrastructure, so modernizing the infrastructure because it's reaching its end of life, it's not functioning in the way that you need to function in a modern hospital, but also the facilities themselves are not modern. They were designed under different models of care, under different models of working and seeing patients. So for us, modernizing is having the facility meet the best standards of care that have been deployed over the last decade, maybe.
And I would say the same thing that Alicia just said, and Mitch. There's a difference, though. There's refresh and remodel for us, which is taking that 1980s patient wing and trying to at least bring it into the 2000s in terms of, colors and finishes. But then there's the modernization where you're dealing with infrastructure changes and changes to the architecture and engineering of the space. And then you're limited by the floor plates. And I've seen in the Q&A, talks about that. We have hospitals that have unwielding floor plates. We have patient units. I have a patient unit sitting on top of a pancake that is too narrow. It's great because we get daylight right into the hallway, but I've got a single corridor, double loaded hallway that was built in the 70s that we're trying to deliver care now in 2022. So it's both. And it's also weighing modernization can be replacement. Are we simply walking away from this old infrastructure and old building and building something new somewhere else? And for us, that's a tall order because we're an academic research medical center tethered to campus and major investments on campus for research and laboratories and other infrastructure that we're tied to. So it's a balancing act. So it can mean all of those things. I don't know if that directly answers the question, Mike, but you can see what's on our plate.
No, and I'm glad. Those are great viewpoints. I think equity is the tough one, as you've both mentioned. You've got the older facilities that date back to could be 50s, 60s, 70s. You've got newer facilities, at Rush Medical Center. When I worked there, we had 3 main inpatient buildings, one built and opened in 1959, one that was opened in 82, and one that opened in 2012. So it's very hard to provide the new modern spaces and provide the equity across the board to clinicians as well as patients. So that's a tough one. Anything in the existing facility seems to be a tough one, especially now with the changing requirements and working in spacing between people, collaboration spaces. So it's like we're expanding up, we're contracting down, similar to what I said in the opening comments. So as facility managers, you deal with more than space, as I recall, and there are other parts of your job that, as Mitch referred to, deferred maintenance. You got to keep these facilities going. And so as well as plan for the all those things that happen in the way of what we might consider emergency conditions, such as a natural disaster, such as fires on the West Coast, such as polar vortexes in the Midwest, such as floods. So how are you and your teams planning for that amidst all the other things you're doing? And is there anything kind of in the way of innovation or planning exercises or drills that you're doing? And I'll just open it up and let one of you grab onto this one.
Well, you know, Mike, you just talked about all the things that are out there. We also got to define what we're not going to do, right? And so philosophically, you know, for example, with COVID, we had about a 1% exposure rate in our buildings. Hospitals are essentially built for infection control. And for the most part, hospitals that were too standard, I think, did okay. I think for our system, it was changing people's behavior that enabled us to not experience those costs. But what we explained to our system is, for example, if ASRE or CDC dramatically changes HVAC standards, then all of a sudden that $1.5 billion maintenance backlog that we had just jumped to $2 billion, right? And so it's really balancing true patient safety, the experience, all of those issues, in addition to continuity of operations that you addressed, right? The reliability of our systems in a comprehensive way as we put our capital programs together. So I talked about we're behavioral scientists, we're, you know, cultural anthropologists, we're economists, we're also risk managers. We're managing risk, all right? And I think when we articulate those risks to our leaders and they can make balanced decisions, because we're not going to get it all done at one time, then that's I think that's the best we can go. And I think Jordan talked about, you know, exposure to data and understanding the way that those systems are performing and operating today is key. When we need to have that data and information so that we fully understand those risks, we articulate those risks, and we give our leadership the opportunity to say, I'm going to go get more capital to address this, or I'm good, I'm comfortable with the risk you just laid out.
I like Mitch's term, managing risk. I think that's in the center of everything. I think one of the benefits, it has changed a little bit the way we work, the pandemic, is that planning, design, and construction and real estate kind of existed off to the side, supporting strategy and our leaders in that move forward through the pandemic, and then with a focus to modifying existing facilities to keep everyone safe. And to maintain business continuity. We are much closer and wired up, much stronger now with our maintenance and engineering services, who also manage our facility emergency management systems and processes. And as an organization, I think we're better having gone through that process for nearly 2 years. But it's all, you know, people are at the center of it and the data is at the center of it. And I keep coming back to people because we can have all the data we want. It's still going to take a person to look at that data and make a call. And you can't get overwhelmed with that, but it's focused on people. And for us, I think it's also a multidisciplinary approach to that. It's not a person, it's lots of points of views coming together to help us manage that risk and make those decisions.
Mike, I would like to add just quickly to this, because we have a practical example of what Mike and Mitch were talking about. We were about to break ground on a new hospital as the pandemic hit, right? And this is where I want to congratulate our whole audience, all our partners, because we had a design that was almost approved by OSHPD. So it was the perfect timing for us to look at it and see, with what we know now, what would we do differently? And the answer was nothing. You know, so I really want to congratulate everybody. There is a small change. We're going to create more separate zones, you know, in the emergency department that can be, you know, work a little differently with our HVAC systems, and a lot of infrastructure on the parking so we can support, you know, more tents if needed. But the bones of this building were right. And when we looked at it with finance, we looked at it with operations, we looked at it with environmental health, we looked at it with every team that would be there, and it works. So congratulations.
Okay, we're gonna move on. We've got a couple more questions coming in, and sticking with the topic of data. There's a question that came in about the 3D building scans and how you can really use the data from those scans, Jordan. And then also, after answering that, if you could just spend a minute talking about whether, because the cost to acquire all this data is so high, as you've mentioned, are institutions really able to use that data for, many years, or does it get so stale quickly? But please answer the first 3D scan data question if you can.
Yeah, so it's I guess the analogy I mentioned of a cart taking about 50 to 70,000 square foot a day, of course, depending on the size of the building. It's loaded up with cameras and LiDAR, so it's able to reproduce the Revit file. It's kind of like going back in time. That's for the existing building stock. Of course, like brand new construction is always coming through with a full Revit, although it's the as-builts are still never truly 100% accurate of the existing conditions. So there's even a case to be made to do that reality capture at the conclusion of a new space. I would just want to come back to the real critical element is that like accuracy of data is it's binary. It's accurate or it's not accurate. If it's not accurate, you need to tell decision makers where it is not accurate. Else those decision makers lose confidence in the information, and not that they're and they tend to, we all do, throw the baby out with the bathwater. So from a information perspective, it's so paramount that we have a approach to accuracy. On cost, it has actually come down dramatically. I mean, it's a bit like the cost of CPUs that has went exponentially. More power for the same amount. We've experienced the same over the years. So we're finding it now to be fairly economical. And when you weigh it against the cost of a poorly informed decision, it's a good value. I'll put a link if I can in the chat. I've got a video that kind of does a flyby of a modeled building that might be a helpful way to see it.
Okay, thanks, Jordan. A question coming in about flexibility, which we talked a lot about earlier, and whether prefabricated units or reconfigurable pods maybe are helping now, because we're seeing more and more prefab in the construction industry. So maybe Nate, you might have a little insight on that in terms of what you're seeing at Steelcase.
Yeah, certainly. So from a Steelcase perspective, flexibility through modular design construction has, been part of our focus for a long while. And, whether it's walls or casework, it's between shortages of millwork or the desire to have that ability to flex a space. Super important. In our business, I mentioned the use of pods earlier for clinician respites or video calls like we're doing today. Those are another example of how the industry has responded, so you could have quick deployment of some of these units without having to take the time or incur the expense to really connect and get into the architecture of a building. So there's a lot more flexibility in terms of space design today with pod solutions, modular casework, walls that are multi-purpose than there's ever been in the past. And of course, the industry continues to look at scale, construction at scale, and look at modular approaches. And I'll let the rest of the panel talk on that level.
I think so. You know, I handle both the capital construction, planning, design, construction, and facilities operations. And to a lot of points that Nate made, there is that flexibility in terms of if you look at the care delivery model, it seems to evolve every 5 to 7 years, where you would think about possibly moving a wall. If you have permanent walls in place, the inclination to do that is less, right? Less, you know. So if you have modular walls, your inclination to reshape that would be higher. But the argument I make for modular is based on access to labor, the quality of construction in a controlled environment is far more efficient than on the construction site. You have less waste. You can recycle that waste that you have in a manufacturing environment. It's a lot tougher when you get on the construction site. So yeah, the first cost is a little bit higher, but for example, with modular hybrid walls, they're much more durable. If you walk in the facilities 5 years later, your product sort of sustains time. So that brand enhancement over time is greater too. So I just think that is an emerging arena, and it's going to be driven through necessity. You talk to a lot of young folks; they'd rather go to a clean environment and work than be on a construction site. It's getting harder and harder to get our youth to sort of saddle up to working in construction for a period of time. We're going to need those folks, to be sure, but we're struggling to find them today, and I think that's only going to get more challenging as we go into the future.
Thanks, Mitch. I think we've been on schedule through this, and in order to keep on schedule and be respectful of everyone's time, we're going to end the Q&A session. There were some questions came in on sustainability, and I'll address that at the end in some closing remarks. So our panelists, I'd like you all to provide a closing comment and something you'd like the viewers and the audience that will help them help you ultimately. So let's start with you, Mike.
Sure. Well, we've touched on several things today, but I think I'll try to sum it up this way. I think the architecture, engineering, and construction industry needs to continue to know more and learn more about operational and business modeling, especially in the world of healthcare, how projects that they are hired to design and build will operate and function. And we can't just simply rely on the templates and guidelines that we have out there. We have a lot of robust resources, but I think sometimes we lean too hard on that and we don't delve into the specifics of our owner's business and how we're going to operate these spaces and how much is it going to cost us over time to operate our business in that space. I would also encourage us all to better understand that systems like ourselves here today, that we're managing portfolios of buildings and spaces, and the whole must be greater than the sum of the parts. So that means we need to focus on the whole and not just simply that project. We want that project done well, but you coming to the table, understanding the context in which that project exists will earn you lots of brownie points. So the language of design is changing. You need to get in fluent in that language. Operational modeling are important. Operational models are changing and affecting our planning. Often we're designing operational models and not necessarily the architecture or engineering. That usually comes after. Decisions are data-based, so getting fluent in the data systems that are out there and being able to offer those types of services to the clients you serve would be paramount. And change is constant. You got to be nimble and flexible. And the work you're doing at the time you're hired is going to change. You can't get bogged down with old processes and the way that you used to work. You've got to be nimble and flexible and work with us as we all change together.
Yeah, it's good that this is being recorded, because I would suggest for everybody to listen to this part again and share with your colleagues. So there's not a lot to add to that, but I want to give you examples that reinforce what Mike was saying. We need you all now you understand that we don't only build and plan, right? So when you come and you ask us about our buildings and our projects, you see that we move in a world that's a little different from buildings and projects, even though that's the end result. So what I would ask is that we change the way of thinking. And like Mike was saying, you can break some of those templates. We don't, we've been telling you, do it this way, it doesn't work this way anymore. But one of our colleagues from SLAM asked a question on the side, and that's what I want to answer as far as flexibility. What we need from you all is difficult. We want you to go fast and we want you to go slow. And that means you need to follow us. And I know that the design, the architectural and engineering industries have very specific ways of delivering projects. And that doesn't allow go fast and go slow. So what we're going to have to change is how the teams are put together, how the fee schedules are put together, how the time schedules are put together, and then create a contract or at least a scope in the contract that allows us to go fast and to go slow.
I'm gonna kind of focus on our owner side. We need to plan the work and work to plan. So if we as owners need to be better at defining our requirements, better at programming, better at planning, a lot of the project delivery process can be significantly reduced by just us making decisions faster. And so I had other comments, but I'm gonna leave that one as my mic drop.
So Mike, I'll step in on this one. There's a reason why this group is called the Built Environment Network, right? We all fundamentally believe that the Built Environment Network, or the built environment rather, has an impact on the healthcare experience. We all believe that. It matters more now than it's ever mattered. And Alicia and others have alluded to this. This is a perfect opportunity to hit a reset. And take advantage of the necessity to hit a reset. So, the other thing I would say, if, on the administrative side, if you're looking to think about having a workspace that's worth the commute and your team's already coming back, you're already behind. Don't wait until your team comes back. Get out in front of it. Give them a reason to come back and take advantage of that, and take advantage of the opportunities that hybrid work provides to make that shift. And think about some of the comments that I didn't make earlier, but we've got to close that gap between those that are co-located and remote employees, so that they feel like there's an equitable experience. Like I mentioned with the neighborhoods, you can create vibrant and energetic workspaces with the diversity, but with areas that provide for that employee experience, where it's either deep focused work or teamwork or collaboration, et cetera. And those spaces have to be pretty intuitive. We continue to learn around how you set up a room. So when you walk in the room, you're instantly on. So the people who are remote are there, and the people who are in the room aren't spending 10 minutes trying to figure out the technology. So, that's really important. And then the last thing, so important to keep that prioritization on the clinician work experience and designing those moments of respite. And the environment can really help in that regard.
I would just say, that we're all here committed to healthcare and the built environment, and wherever we are in that whole life cycle, to just remember that the data we're working with can have very valuable uses elsewhere as a byproduct of existing workflows and systems. So have empathy, think about how other teams may use it, extract it, mine it, structure it, and turn it into something really valuable.
Thank you, Jordan. There were some questions on sustainability, and obviously a renewed interest in climate change and how to respond to making changes in this area. We didn't have time to discuss this today, but in the past year, the National Academy of Medicine formed a group called the Action Collaborative on Decarbonization of the Healthcare Industry. And the BEN group is now a network organization in this collaborative and will participate in sharing sustainability and decarbonization plans from their respective organizations. So you'll hear some updates about this work and other updates at the BEN session, at the Healthcare Design and Expo session in October. So please join us then.
Okay. Well, thank you again, Mike and the panelists. I want to again thank Pat Kraft, Acorn VAC, and Samsung, our industry partners, whose generous support helped to make today's Voices of the Industry session possible. And we appreciate their longstanding commitment to our industry and our collective efforts to make the built environment better for people. I also want to thank members from the Built Environment Network. One of the things that I get to do in my role at the center is to program and facilitate the BEN meetings. And it's a joy to work with the members of this group. So if you would like to learn more about the criteria for joining BEN, please reach out to me. The network is a wonderful opportunity to learn and connect with your peers in the industry. And to learn more about our Future Voices series and other partnering opportunities with the center, please reach out to Randy Carter, our Vice President of Relationship Development, and you can see his contact information and phone number there. And so I'm closing to say thank you so much again for attending. Take care, everybody. Stay well and stay safe.